This episode of Transmission Interrupted was recorded May 26th, 2026. This is Transmission Interrupted, a podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Welcome to Transmission Interrupted from NETEC.
Hello, and welcome to Transmission Interrupted. My name is Jill Morgan. I'm a nurse here at Emory University Hospital in Atlanta, Georgia. For those of you not yet familiar with NETEC, our mission is to set the gold standard for special pathogen preparedness and response across health systems in the U.S., with the goals of driving best practices and closing knowledge gaps and developing innovative resources. NETEC works alongside and in cooperation with the CDC and is funded by ASPR, the Administration for Strategic Preparedness and Response. I am thrilled today to get to talk to two friends of mine who just happen to be brilliant women in their own right. Today, we're going to talk to Vicki Herrera. Vicki is the Biocontainment Laboratory Training and Education Leader for UNMC in Omaha, Nebraska. She's been in clinical labs for more than 20 years. Colleen Kraft is the Medical and Laboratory Director of Emory's Biocontainment Unit here in Atlanta. She's a professor of pathology and laboratory medicine and a professor of medicine and infectious diseases. These two brilliant women co-lead NETEC's laboratory work group. I am thrilled to have you guys here, and we're going to try to demystify what we mean by basic labs and how we can help healthcare facilities at the front lines get prepared to actually deliver clinical care for a suspect or confirmed special pathogens patient. So welcome, and thanks for joining me today, ladies.
Thanks for having us. Thank you.
Absolutely. Okay, so when I think of a patient presenting to an emergency room or, wherever, even in urgent care, I think about what immediately happens. And I know that, like in a really efficient, busy emergency department, many times somebody's like drawing a rainbow and shipping it off to the lab, and we'll talk why we don't want that to happen in a second. But I think about what clinical care we want to be able to deliver to somebody who might have the vague symptoms of these presentations. So fever and vomiting, fever and cough, fever and nausea, or malaise, body aches, headache, all those things. And I think typically we would want to order a CBC and a 7. That might be the most basic thing we want to do. But how do we do that safely for a patient like this? So can we start with how you guys define basic labs and maybe a little bit about how we get there?
Yeah, I think we may have to clarify a few terms, such as a rainbow for this audience, but that just means that they draw all the tubes that they usually draw for any type of lab, so that when the laboratory needs something or when the provider wants to add something on, then they have it already in the clinical laboratory. So I think the reason that we can't or we don't necessarily think about that is that we want to make sure that we can do all of those laboratories safely. So I think I kind of want to answer your question in two different ways, if that makes sense, Jill. One of them is if you are knowingly testing somebody that you have very high suspicion that may have Ebola virus disease or something else like Lassa fever, you want to make sure you're doing the testing in a very controlled environment. And that's what both Vicki and I get the privilege to do at our institutions. And so in that case, you really can only order what we can do in the biocontainment environment. That might seem a little austere if you think about all the things that the clinical laboratory can actually order and do on a regular basis. But in this case, it's really to make sure that we're not missing anything that's life-threatening, while at the same time making sure that we have sort of a baseline or a standard for what's going on with that patient on that day. So for instance, I would consider a complete blood count or a CBC, a basic metabolic panel. So that was the Chem7 that Jill was referring to. We can add on a few other things besides that. In our laboratory, we can do a urinalysis, pregnancy testing, which can be done on more like a point of care, which we're going to get to what that's called or what that's about. And then I think especially in our patients that are returning from travel, we always test for malaria, which we can do by either a molecular test that we have in our laboratory, or we can do sort of more of like a lateral flow assay, if you want to think about it that way, where we can do like almost a malaria test just by lateral flow. So I think those are what I consider our very basic tests. Now, again, if you have somebody that's now approaching the emergency department and you're not quite sure what to do in that setting, and you're worried that they may have something like Ebola virus disease, like sincerely worried, not just, sort of superficially worried, the things that we want to think about are probably the same. We want to make sure that they don't have something else that's life-threatening. So that's usually going to involve, again, CBC to look for severe anemia. I think the electrolytes are absolutely critical in these people that have vomiting and diarrheal illnesses. We think that a lot of deaths that happen in Ebola treatment units across the world happen because of electrolyte imbalance, not necessarily because of the virus itself. And we may want to do, depending on how sick the individual is, we may have the opportunity to also do a blood gas analysis for like a venous blood gas. But remember, where you're setting those labs also makes a big difference. If you're not going to be able to do those labs in your regular laboratory, or if you have to do something special around them, I think really trying to work with the laboratory leadership to understand what you can. And remember, these things should be available 24/7 with rapid turnaround times in order to help patients not die from things that they may be coming here with.
It's a great point. And I'm glad you sort of separated what happens being a biocontainment lab like you and Vicki are used to on the regular, but also in an emergency department or in an urgent care, and thinking really, making sure we bring the laboratorians in, because I think this is where, to me, we have a lot of ED providers who are used to being able to get lots and lots and lots of results very quickly for a patient, which is great, right? Helps patient care. But then we have laboratorians who are like, wait a minute, this is not just a normal specimen you're asking me about. This might be a special pathogen kind of event. I don't want to run this on this, or I'm not prepared to do this. And so the disconnect between what providers might think they need or think they want and what labs can provide is this ongoing sort of gap or tension. And maybe thinking about, okay, so I can't get everything I want. It's like Christmas. I can't get everything I want. But what is the one thing that would make me really happy? Well, a CBC and a basic metabolic profile, as you said, or basic metabolic panel profile. Which one is it?
It's probably been all of those throughout the time of our lives, but yes, I think it's a panel.
I think it's good to make sure you're opening up those conversations. So if you're a laboratorian, you need to go talk to ED providers. And if you're an ED provider, you need to talk to a laboratorian. If you're in an urgent care, you might need to talk to your techs who are over your laboratory to make sure that you have the devices that would let you look at these things, because we don't want people to suffer bad consequences from lack of care. And so I want to sort of pivot that to something I admit complete ignorance on until recently. We've been using this term point of care. I know people here that are friends of mine, have been friends of mine for years, and they're like, we work in point of care lab. But the only time I saw them as a bedside nurse was when they came up to do like an update on a glucometer or one of those other things that we would keep at the patient's bedside. So that's what I thought point of care was, an iStat, a glucometer, something like that. But I understand that actually point of care means a whole nother thing to those of you in the lab world, which is a much wider and broader group of devices than I would have expected. So can we talk a little bit about what you guys mean by point of care and what's the difference between a point of care device and what happens in that mystical, magical place we call a core lab?
Well, you're not wrong, Jill. Like point of care, it does include iStats and glucometers and things like that. Generally, the point of care instrumentation is portable, it's smaller, it can be done at the bedside or at the point where somebody is getting cared for. So that's general terms for point of care. There are some larger instruments that are still considered point of care. They're generally easier to use, less requirements with them, but we still utilize those pieces of equipment, but we use them in our biocontainment units so that we can really use them away from our main core laboratory. The core laboratory has some bigger pieces of equipment depending on the facility that you're at. They can be really quite large, and A lot of times the labs are open concepts, so you have multiple people walking in and out of areas, doing lots of different things in there. So we utilize the point of care so that we can really put those in our biosafety cabinets, keep them more contained, and use them in a smaller, more controlled environment.
So if you're in a doctor's office or a urgent care and they can turn around like a CBC and a chemistry of some kind, those are probably being done on some sort of point of care device?
Some of them, yes. They're just a smaller device that you can have close to the bedside.
So the two of you, when you're thinking about education that your work group is working on and the things that you prioritize for level 2, 3, 4 facilities, can we talk for a minute about like lab safety and how you go about thinking about a risk analysis or how labs should think about whether they can do this or not?
I would say that we have to be able to do laboratory testing. And so it shouldn't be whether or not we can. That's not really the answer. And I'm only saying that because we've had that scenario happen to us a few times, and I'm sure in Vicki's region as well, where the answer is we're not going to test the patient because we're worried about this, rather than we need to figure out a way to avoid or make ourselves as risk-free as we can while testing in order to help the patient.
Vicki, so tell us more about what a lab risk assessment looks like.
Yeah, so really what we're looking for when you're talking special pathogens is looking at things that would expose the personnel to some of these pathogens. So you want to look at every aspect of your test that you're doing. Are there sharps involved? Are there possibly aerosols that are produced? Are you centrifuging? Those are all, laboratory terms if you're not familiar. But just things that may expose the laboratorian to the pathogen, and looking at these with a much deeper dive than your normal clinical laboratory testing. The special pathogens have a lower infectious dose, and so we really want to scrutinize a lot more of things that could possibly expose the laboratorian. So taking a deep dive into that is going to be helpful in determining not whether you can do it, but what safe mitigations you can add to doing that test in order to be able to do it. We don't want you to be scared of doing the labs, but we do want you to make sure that you're taking appropriate cautions. So that may be doing something in your biosafety cabinet, that may be adding extra PPE, adding some engineering controls that can help you safely mitigate doing the test on the pieces of equipment that you have. And that can look a variety of different ways in a variety of labs. We like to say, if you've seen one lab, you've seen one lab. So every different laboratory can look completely different, and you may need to adjust based on what your workflow is, your airflow, and what pieces of equipment you're using.
Yeah, so this is not something that a laboratory needs to do by themselves. Like, you probably have infection prevention if you're at a hospital, and you might have somebody else who comes in, and I know in many places there are actually lab safety people. And so thinking about walking through those. Okay, so what would I do in this circumstance? I love, Vicki, you mentioning this risk assessment, because I think both as a clinician, if you're an ED nurse or provider versus a laboratorian, we both should be using the standard precautions that keep us safe most of the time we do our jobs. But when we know that there's this heightened risk, right? Like you said lower infectious dose, scarier, they're whatever. We really need to think about what steps we can take to ensure our own safety above and beyond the standard precautions. At the bedside, we might call those transmission-based precautions. And in the lab, you're really talking about like, what transmission risks do these devices add to my workflow? Either way, we want to react with, this is what I can do to mitigate those risks versus, I'm scared, I don't want to do this. And I'm certainly not saying that healthcare providers or laboratorians are consciously doing it. But things do scare us. And we hear about these pathogens, we do not know much about them. And suddenly here somebody wants us to handle that blood. Well, that is kind of intimidating. I mean, I understand people being sort of anxious about it. But if we do it right, in case tell me I'm right about this. If we do it right, then we can really minimize any risk that is presented to a laboratorian or a healthcare provider of any kind.
Absolutely. I agree. These sometimes sound really scary, right? There's a reason, and we know that laboratory infections have occurred before. So it is a little bit scary, especially when you hear something that may not have a current treatment. But yeah, I agree that I cannot state this enough, but communication is really key in this situation. Notifying your laboratory as soon as you possibly can that this may be a possibility. That way they can implement some of their mitigation strategies, rather that's PPE, rather that's designating one or two people to be in the area at the time, or whatever that mitigation is. By communicating early, the laboratory is aware and they can take extra precautions in these situations.
Yeah. And I think that's one of the things that we try to emphasize to those people who might be getting these specimens, right? So typically in many of these situations, we're not calling phlebotomy in to draw these. If we have a suspicion, probably the one person we can put in the room who can get a good history and do a good exam and put it in an IV, maybe the one drawing your lab specimen or getting that nasal swab. So I think it's important to say we want everybody to use caution. We want people to not pass risk downstream. And that means that a specimen needs to be clean. Don't send those nasty, covered in blood specimens to your lab. That's just not fair, especially when you're talking about something that is fear-provoking as a special pathogen. So you mentioned PPE, Vicki, and I want to get back to that because, of course, it's my favorite topic. But also, are there some everybody should do this with PPE rules in the lab, and then you just add layers on top depending on what you're working with? Or are there special things that you think laboratorians should all have in order to handle specimens from patients like this?
Well, you probably know better than I do on the PPE. You do such a great job with PPE, but definitely with your PPE, you need to practice, right? It's not all the same. Not everybody has the same PPE, so there's different things you can do. We talk a lot about working in a BSL-2, which most core laboratories are a BSL-2, but we talk about using BSL-3 precautions, right? So that would be a fluid impermeable gown, adding that to your list. An N95, maybe a face shield, doing something to cover all those mucous membranes, maybe double gloves. It really kind of depends on your facility. That may or may not. Actually, BSL-3, you would usually use double gloves. Some people use triple gloves. That's a whole different story. Adding those things, but you need to practice, right? You need to be able to get those gloves off safely. You need to have a procedure for doffing all of that stuff and where you're going to put it as well. So again, practicing all of that. But again, every lab is a little different and what they have on hand may be a little bit different. But in general, covering all of your mucous membranes are going to be an important thing here.
And it would seem like a lot of that would depend on whether I can do what I'm doing with a specimen, like inside a glove box or under a hood. And PPE etiquette, just like we know it at the bedside, is super important. You can't have your hands up under that hood and be dealing with the specimen and then reach out to get your pen or reach out to get something else. Obeying sort of the rules of once your hands are under there, we're going to consider them dirty and we're not going to touch other stuff in the lab with those hands.
Yes, if you're going to use your BSL-3 precautions, once you're in a biosafety cabinet, everything stays in there, including that outer layer of gloves. You don't want to bring that out. You don't want to touch other things, especially if you opened a tube, because that could potentially aerosolize some things. You also want to just change your gloves a lot in general. If you're touching that specimen, you're moving it, you don't want to touch other pieces of equipment. So just being very mindful of what you are touching and how often you should be changing those gloves, not touching your face. Everybody wants to adjust their glasses or they have an itch that they need to scratch. Being very mindful of that when you have your PPE on and not touching anything really, which is, easier said than done because people touch their face more often than they realize. And so really practicing with your PPE and having somebody observe you and noticing and having maybe that partner that's helping you just to say, hey, wait, don't touch anything, or maybe, they notice a little splash that needs to be cleaned up right away. That extra person to observe you can be very helpful as well.
Yeah. We tell people all the time, like, don't touch your face, and use a trained observer or someone similar, like you said, a helper or observer that can hand you something if you need it, rather than having you move your dirty hands out from under a hood. And I think about that whole idea of leaving the dirty gloves where they are, because you don't want to just turn around and here you've been so worried about these things inside the hood, and then you're just going to contaminate the rest of the lab. Like, that defeats the whole purpose.
Well, and just the way the clinical lab is laid out as well, their processes and their workflow tend to be a little bit different than when you're dealing with a special pathogen. So like you may have a biosafety cabinet that already has some of their supplies in it. And really when you're working with your special pathogen or the potential to have that, you want to clean all those supplies out and only bring in the stuff that is necessary. So you might need to clear off both your biosafety cabinet and the work area or space around the instrument, just to ensure that if there were a splash, that you're not contaminating extra pieces of material that you don't need.
Yeah. And if I were manipulating like all the tubes and toppers and things like that you guys have to do, I would think that practicing with 2 pair of gloves on is really important, because I know how hard it was for me. I mean, it sounds dumb, but one of the most frustrating parts of dealing with Ebola patients was the very simple act of having 2 pair of gloves on and not being able to open a Band-Aid because you just couldn't feel that tiny little fine wax paper, or finding the end of a roll of tape. And you think, oh my gosh, this is just going to drive me crazy. But I imagine in lab, you guys also have all these little tiny fidgety things you have to pick up that might be hard if you're not used to doing it in 2 pair of gloves.
Yeah, absolutely. It's worth practicing in 2 pairs of gloves just to feel how different it is to pipette, open tubes, some of those things that you do take for granted with the tactile sensation.
I know we need to wrap up, and I wanted to just sort of go through a few points that you and Colleen have made. And I think it's worth reiterating something you said early on, Vicki, which was communication is so important. So the only way we're going to close the gap between what bedside clinicians, care providers want to deliver and what laboratorians can and will deliver is to talk about it. Got to talk about what the expectations are, what the needs are, how these things will happen, how can we do it safely, what's the turnaround time? Are there other ways to do it, like maybe utilizing an iStat or a VBG machine that isn't used very often to at least get me a little bit of basic chemistry? How can you bridge that gap so that we can deliver good care and not put anybody unnecessarily at risk? And then I think this whole idea of what a point of care device is, again, like I had no idea that a Pochi or a Piccolo or a Gem was a point of care device. Like I didn't think about them as being point of care. And I know you call them portable, but to me, they're just sitting there. They're not like an AccuCheck machine or a glucometer or whatever that I'm taking in and probably putting on my patient's bedside table. So I'm glad to know that all those devices that could be really helpful for people are also just considered point of care. That still means they have rules to follow, right? I mean, lab is an extremely well-regulated industry. But it might mean that a point of care device is much easier for somebody to think about using than it is to think about sending a specimen to their core lab.
Yeah, absolutely. So I think the important thing to do really is to create a team, some leadership in your laboratory that can discuss things with the providers, anybody else that needs to be involved. That could be a variety of people, right? So creating some sort of a team where you can discuss those things and really discussing with the providers, what are the tests that you really, really need? Not what you want, but what do you really, really need? And then the lab doing a risk assessment on that side to figure out how they can provide that for you. And a point of care device may or may not be the answer. I mean, there's a lot of things that come into play with that, right? There's regulatory issues. You still have to follow all the regulatory standards. There may be a cost issue. There may be only one in your ED that you may not be able to dedicate to a particular patient that you're investigating. There's a variety of reasons. So really walking through those, doing the risk assessments, determining, is this really the safest way we can do it? Is this a possibility, or do we need to relook at something and do it differently? And then communicating that back to your providers so that they have a clear understanding as to why or why not you are able to provide those particular tests. Again, you may have to go back to the drawing board, but as long as you can have that communication back and forth with your providers as to why it's feasible or not feasible for that particular instrumentation and those particular tests are going to move the needle a lot faster than just saying yes or no to things.
Yeah. I thought you were going to break into the Spice Girls song, telling you what you want, what you want. So I think that the other piece that I just want to get in here, because I have been threatened every time I come up with what I think is a brilliant idea about lab, I get told I might go to lab jail because it is such a regulated industry. But that's, of course, for the protection of our data, right? We want to be able to trust lab results, and therefore we have to be really persnickety about who does what and on what devices and how those devices are validated and all that stuff. So I don't mean any disrespect to that. But for somebody who says like, oh, our ED doesn't currently use an iStat, but if we had a potential Ebola patient, we could just use one like from another unit. Well, no, because those nurses aren't checked off on that device. We have to make sure all those pieces are in place. Like, it might sound easy to do, but there are some rules about why that can't just be thrown in at the last minute. And so your advice to like really talk about this and have a meeting and have the right people at the table ahead of time is, I think, critical. Not just for avoiding lab jail, but for making sure we're getting the results that can be trusted.
Yeah, agree. There's a lot of regulatory things that do go into bringing up a test, and you do still have to follow all of that. And sometimes it takes a little bit of time to get that, especially if you're bringing a new piece of equipment. It does take a little bit of time to bring that up and have that test available. So those early conversations are really crucial in making sure that the providers have the test that they need to provide adequate care.
All right. So when we say every healthcare facility should be able to offer a patient who presents with a suspected or confirmed special pathogens patients, we're talking about Ebola, Lassa, Marburg, MERS, all those things. Basic labs would include a basic chemistry. So whether you call it a BMP or a Chem 7, we're talking about some electrolytes. We want to know a little bit about their CBC, and maybe we won't get the whole thing because I know some of those are available. Maybe you get a hemoglobin and a hematocrit on an iStat, or you might get a white count on something. You get the idea. Parts of a CBC, chemistry, maybe a urine pregnancy, if that's the patient population that you might be taking care of. A malaria test would be a really value add because so many of these suspect patients end up with malaria. And then everything else is really gravy after that point, it sounds like. That if we can get those down, the rest are just like bonus prizes. Does that sound right?
Yes, but keep in mind that not every single facility may have all those tests available or be able to provide them, right? We want them to be able to provide basic stuff, right? But that's also where those conversations come into play. And if they aren't in a position that they can offer some of those or offer what the physicians really need to assess, that is where you phone a friend, right? So maybe you have a facility nearby that could offer those tests. So that might be a conversation with your partner lab. I don't want to say reference labs. We don't want to send stuff to a reference lab, but a reference lab could mean different things to different facilities. It could just mean their larger laboratory that's associated with their facility, right? So making sure that you're having those conversations. And if you can get something maybe that the larger laboratory is able to provide. Again, making sure that you keep all of those safe practices and again, having those conversations about what makes sense and what you can and cannot do in your laboratory, but still being able to provide the testing that they need in some way.
Yeah. And then before you think about what you need to wear or how you need to do it, you need to think about a risk assessment for what handling these specimens and doing those tests that we just mentioned might entail. If which equipment you're going to be using, what risks specifically might you have, so that you can make sure you're addressing those risks with your choices of protection mechanisms. Parts of that are PPE. Parts of that, like Vicki said, would be things like knowing where your airflow is. Are you using a hood? Do you have negative pressure somewhere? Are you using a glove box? Because those change what PPE we might really say is super important to that situation. So basic labs, risk assessment, and then thinking about the importance of this communication so you understand everybody's on the same playing field for how we can advance the medical care these folks desperately need.
You hit the nail on the head.
Well, thank you guys so much to Vicki and Colleen. I know that the NETEC laboratory working group is in great hands with the two of you. So thank you. For those of you listening at home, thank you for tuning into this episode on Lab Basics. We hope you'll join us for future episodes on a wide range of topics. We've talked about everything from crash to treasure and healthcare worker safety and personal protective equipment. So please think about subscribing to future episodes, which you can do at netec.org/podcast. If you have questions for NETEC or ideas for future shows, please feel free to contact us at info@netec.org. And we appreciate you being here, and we hope we'll see you next time on Transmission Interrupted.
You've been listening to Transmission Interrupted, a NETEC podcast, produced and edited by Benjamin Madsen, with additional support provided by Britton Clark, Veronica Lavaro, Jason Noble, and Lisa Stone. Special thanks to our guests and the subject matter experts at NETEC for their insight and guidance. This podcast is supported by the Administration for Strategic Preparedness and Response. For more information, tools, and training on special pathogen preparedness, visit netec.org. And don't forget to subscribe, rate, and share the show on Apple Podcasts, Spotify, or wherever you get your podcasts. Thank you for tuning in to Transmission